So hi everybody, my name is Chris Williams, and I'm the Director of School-Based Mental Health and Wellness at Sacramento County Office of Ed, or SCOE. Different from SCO, we're SCOE, where we just add a little emphasis at the end. I'm joined here today by several of our partners, Dr. Ryan Quist, we have Dr. Mishra, and Jaspreet Sodhi. And we're going to kind of split this up a little bit, and I'm going to talk a little bit about our program, our partnership, School-Based Mental Health and Wellness in Sacramento County. I'm going to talk a little bit about the nuts and bolts of that, why we decided to start it, what we're currently doing, and how we're funding it. Dr. Quist is going to talk a little bit about the partnership with behavioral health. And then Sumi and Jaspreet are going to talk about the financing and kind of next steps. And our goal will be to leave about 20 minutes or so at the end for questions, if you have questions around what we're doing. And hopefully, if you take nothing else from what we're going to say over the next hour or so, is that you'll take away the fact that this is a partnership. And that everything that we've been able to accomplish up to now and everything that we expect to accomplish over the next several years is because of the partnership that we have. I don't know if you happen to notice we were sitting in the back, but we were having a lot of fun back there as the troublemakers in the back, because we haven't seen each other in person, live and in person, like all four of us actually, and I think it's been 2 years since we've actually been together in person. But what we do every time we get together virtually is we check in with each other, and we chat about what's happening in our lives and what we did over the weekend. And that relationship that we've built is critical to this partnership. And what we're going to talk about is what we're doing, but we're also going to talk about is how we've done that. And how we've done it is through this partnership and through building relationships with each other, because we already, everybody up here already had a full-time job before this partnership came about. And so we're talking about how are we aligning our interests, aligning our goals and our values to come together really in service of the students and families of Sacramento County, and that it's about this partnership more than anything else. The what is really important, but if it weren't about setting the conditions for our success first and foremost, the success wouldn't have happened. So I just want to outline that first, and then we'll sprinkle it through as well in terms of how we're working together, how we're supporting one another, and how we're accomplishing our goals, and also readjusting our goals as we go along. Okay, so it's really important to start with the why. Why school-based mental health and wellness? And I don't think we probably have to spend too much time on this with this group. I think we're all here because we have a pretty strong why. But what we identified is that there's a need for really comprehensive and integrated school-based supports for students, focusing on not just treatment, yes, treatment, but really also focusing on prevention, school climate, and diagnosis and treatment, leading to these improvements that are academically related, but also health and mental health related. So really important for us to ground ourselves in just some of the recent research. Dr. Jack Shonkoff, who many of you are probably familiar with, runs the Center for the Developing Child at Harvard University. He wrote a paper several years ago in the journal Pediatrics, where he talks about the lifelong effects of toxic stress. Toxic stress is defined, of course, not just by the normal stress response that we all encounter, right? But that when we reside in that stress response, that's when it becomes toxic. And he also talks about that development is driven by this ongoing inextricable link between ecology and biology. Essentially, what that means is that age-old question of nature versus nurture has largely been put to bed. It's not either or, it's both. And that we have to focus on the environments we are co-creating with young people to adjust or ameliorate the toxic environments from which many of them come. A lot of this is coming out of this research on toxic stress and adverse childhood experiences, and really developing a new field of study called epigenetics. And I know the first whole day was really talking about this and the neuroscience of this. But that we really co-create experiences, and it's those experiences that drive development. Really important for us to understand this when we talk about schools as centers of wellness, that every single day we are co-creating experiences with the kids we serve, and how we do that. and the level of intentionality we bring to that co-creation of those experiences is critical to shaping their future development. Particularly when we think about the development up to this point and potentially toxic or adverse childhood experiences that they bring into schools with them, we have to keep that in mind, and how are we co-creating experiences moving forward. And of course, we all know that the experiences kids are bringing with them right now, these are pre-COVID statistics, right? And I'm sure we're all enmeshed in this, right? How the level of anxiety and depression has skyrocketed in the last 20 years. The level of suicidality has skyrocketed. Suicide has now jumped to the second leading cause of death for adolescents. And of course, COVID didn't make any of this better. COVID really made all of this worse. And that last bullet there is that California is really pretty bad at really drawing down federal dollars to support this. We're actually towards the bottom of the list. Also, we also have to understand the impact that COVID has had, and very presciently, our Surgeon General mentioned that COVID is going to just exacerbate all of this. And finally, we cannot ignore equity, and that all of these negative outcomes that our kids are experiencing these days are made worse if you're black or brown, right? That the outcomes related to experiences of our black and brown youth are far worse than kids who look like me. And so we have to take that into consideration, and transforming schools into centers of wellness does not mean just tweaking around the edges, but actually rooting out the existing structures that are racist, and those systems, and how do we actually root that out. So everything we're doing is coming at it through an equity lens, and understanding that we have to recognize these differences and work to address these differences moving forward. So here's the good news, is that in that same article, Dr. Shonkoff said that the essential characteristic for mitigating toxic stress, the essential characteristic is the presence of what he calls a protective adult relationship. And that relationships that adults form with young people in and of themselves are an intervention. And what he talks about is that if young people are residing in that stress response, that getting with a caring adult, even if it's for a couple of minutes or one class period, it gives us a break from that stress response and allows us to come down from that stress response. And again, toxic stress being defined by the prolonged activation of the stress response. If we interrupt it even briefly, it's no longer toxic. It gives us the opportunity to have our stress reside in the manageable category as opposed to the toxic category. So, I ask, who is better positioned to form protective adult relationships with kids than the adults with whom they interact every single day? The adults in schools. And so schools must be a central factor in addressing the mental health crisis in the United States and in California. And that's really what we're working on. And it's what all of us are working on, right? The panel previously, but really transforming schools into centers of wellness so that we can actually work to mitigate these crises. And that's what we're going to talk about, this coherent, integrated, scalable system that we're building in Sacramento County. So it's a partnership, as I mentioned. We're really working on a collective impact model. This is not a SCOE program. It's not a county program. It's not a district program. It's a program that really is built with and for and to support all of those. Collective impact often requires that there is a kind of a backbone agency, and so SCOE is kind of standing ourselves up as that backbone to hire the staff, train the staff, but in partnership with our county partners who already have the federally qualified health center, and I'll talk about that in a moment. The federally qualified health center being the mechanism to serve Medi-Cal and to draw down those federal dollars through reimbursements. And then, of course, the schools and the districts and all of the folks who make that up, the parents, the young people themselves, all the stakeholders in schools, all of them are essential partners. And we work to bring those partners together several times throughout the year through a mental health and wellness collaborative. Our clinicians meet with the county-funded clinicians. CPS has recently joined that meeting. So we really work to include everybody's voice in the direction of this program while we are also building it. I know that sometimes that analogy is like we're building the plane as we fly it. The analogy we like to use is that we're building the sandbox while we're playing in it. Seems a little bit less scary, and we're all playing together, right? We're all trying to figure this out and building some sandcastles, but meanwhile we have to kind of frame the sandbox, frame the boundaries for ourselves, and that's the analogy we like to use. So the vision, as you can see here, is bringing these systems together, the education and healthcare system, to create a continuum of care. We'll talk a little bit about MTSS and the tiered system. We really have to think about this as a continuum. Kids don't reside in Tier 3 or Tier 2 or Tier 1. They float back and forth, and we have to think about this continuum not just in schools, but the continuum outside the school as well with all of those partners. Our mission, in collaboration with our 13 districts, to identify and address the mental health needs of students. Identify is a big piece here, right? So how are we doing case finding? How are we using data to inform who we need to reach out to? Doing outreach to parents, community members, creating a coordination of service team at every school. We'll talk about that in a moment. And then addressing this, as well as providing training for everybody in the school around Tier 1, Tier 2 social emotional learning, so that every adult in the building understands they have a role in supporting the healthy development of the kids they serve. Academically, sure, but also socially, emotionally, psychologically, physically. Schools as centers of wellness means that every adult understands and accepts their role in supporting that healthy development of the kids they serve. And that work resides with us in terms of how we educating, training, supporting those adults. Our goals are academically related as well as mental health and behaviorally health related. We are formalizing a partnership right now with some folks at UC Berkeley to do some evaluation on this. And then our funding, and Dr. Mishra and Jaspreet will talk a little bit more about this in a minute. But the county operates a health center, Sacramento County Health Center, which is a federally qualified health center, an FQHC. It's that status that allows them to draw down medical, federal reimbursements through Medi-Cal, right? So we are applying through the federal government to extend that FQHC status to the schools themselves. So the schools, on paper, and as endorsed by the federal government, become satellite centers of the FQHC. So then we, SCOE, hired the clinicians, LCSW, LMFT, PsyD, place them in the schools. They provide the direct mental health services, so assessment, diagnosis, treatment. They log all of their documentation in the County Electronic Health Record System, or EHR. When they hit that close note button, that triggers the billing mechanism, which then sends the claim to Medi-Cal, and then we get reimbursed at the predetermined, what they call prospective payment system, or PPS rate for the county. So essentially what we are building is a self-sustaining program that is not grant funded, it's not time bound, it can go on in perpetuity as long as kids present with challenges and we address them through this system. And as far as we know, we're the only county who's doing this. A lot of folks are doing the partnering with behavioral health, and a lot of folks are doing great things. We're the only county who's doing this through the FQHC. So we're really excited about this model, and we're really excited about continuing to measure the effectiveness of it. Currently, we're in 20 schools, and we'll talk about this in a minute, but we're expanding to 40 schools next year. We're 13 districts in Sacramento County. We're currently in 10 of those districts. We're going to 11 districts next year. So 40 schools in 11 districts as of August. So I just talked about this. We hire the clinicians. They provide the direct mental health services. We've designated, or we've kind of speculated that 60% of the clinician's time will be spent on those direct mental health services, which leaves 40% of the time to do the engagement and outreach, Tier 1, Tier 2 supports. We have a partnership with the Yale Center for Emotional Intelligence. They have an approach to SEL that they call Ruler. Every school that we work with has the option of sending a team on us to that training to integrate Ruler into their schools as a Tier 1 approach. It's in our MOU that every school has to have some approach to SEL as a Tier 1. The coordination of services team is also in our MOU. There has to be a mechanism for navigating referrals. We call it a coordination of services team. We're also looking to partner. We have an early learning department. Obviously, there are other providers here in Sac County that do early learning. So establishing that kind of beachhead in the schools, but using that beachhead to reach out to other folks in need, understanding that kids don't start developing at age 5 when they come to school. So we actually have to have some attention to that. And then, like I said, we have these MOUs, and all of this is funded through Medi-Cal. The first cohort of schools was about 60% elementary schools, 40% secondary, which is roughly the average, right, and the county and state average. These are the schools. Again, the acronyms are the district that they're in. Second cohort of schools, so this is the schools we're in now. There's 20 right now, and we're moving, like I said, to 40 next year. The vision, of course, we want this to be in every school in the county. It's about 350 schools, so that's our goal, is to get to 350 schools-ish in Sacramento County, and that's what we're heading towards. Some successes up to this point: proof of concept. We didn't know this was going to work. We started this knowing that we needed to address the need and we needed to do something different. Well, we're doing it. We're submitting claims and we're getting paid, and so it works. So we're going to keep doing it. Ruler, as I mentioned, the partnership with Yale Center for Emotional Intelligence. We've sent about 100 schools so far in Sacramento County. Again, our goal is to send every school there if they want it. So far, every school has wanted it. Coordination of services teams, I'll talk a little bit more about that in a second. We find that to be essential. And we've mentioned it a couple times now: collaboration, county behavioral health, county primary care. We have this collaborative, school-based mental health and wellness collaborative. We have partnership meetings about every month with all of our school partners and district leaders. They're very well attended. We've been doing this all virtually. We launched this in the middle of a pandemic. Just a little tip: if you want to start a brand new program, don't choose the middle of a pandemic to do it. Just my tip to you. But we've been doing this all virtually so far, and we're looking forward to doing it in person. And then ongoing clinical services, again, just continuing to provide these services. And this is how we think of our coordination of services team. If you think about how referrals often work in a school, is a teacher refers directly to the clinician. What we want to think about is that there is multiple different services at these schools: Tier 2, mentoring, small groups, as well as classroom supports, as well as those Tier 3 clinicians, and there's also district-funded clinicians. So we want referrals to come into cost, and then cost act as the navigator to those different systems. So the red arrow is all referrals. All referrals come into the coordination of services team. That team acts as the navigator, first to investigate and find out what's actually going on. In some cases, we may actually give the referral back to the teacher and say, there's some stuff in your classroom that you could be doing, and we can help, but this doesn't rise to a level of a Tier 2 just yet. We are looking to employ peer specialists next year. We're really thankful for that designation to be moving forward, to provide mentoring as a Tier 2, near peer or peer mentoring, as well as small group work, student-led initiatives. So that's essentially the nuts and bolts of it. We're going to have some questions in a minute, but these are the nuts and bolts of the program. And at this point, I'm going to turn it over to Dr. Quist, who's going to talk a little bit about how behavioral health folds into this. And then Sumi and Jaspreet will talk about the funding model.
All right, good afternoon. Ryan Quist, Sacramento County Behavioral Health Director. I want to start off and just acknowledge and reinforce the importance of this partnership and thank Office of Education as well as our primary care clinic for their partnership in this. We know that no one person, no one entity, no one alone is going to be able to address all of the behavioral health needs within our community. So this partnership is really, I think, sort of a brand new piece of the puzzle that's needed in order to address the behavioral health needs of the youth in our communities. So really appreciate that partnership. I also need to appreciate the support of Superintendent Gordon, at Sacramento County Office of Education, as well as, in particular, Supervisor Patrick Kennedy, our Board of Supervisor, as well as the rest of our Board of Supervisors, because without their support, this wouldn't be happening either. So really appreciate how we've all come together in this initiative. Now, I put up on the screen a picture. Now, you're not supposed to be able to read that all, so don't worry. But what I wanted to do is I wanted to give you sort of a little bit of a picture of that this is a broad initiative that we have that's focusing from a county behavioral health perspective within this broader array of our services. What you see on the screen is our array of services. On the far left, you see our prevention early intervention services, and then as you go further and further to the right, it gets more and more intensive as you go. And so over on the far right, we start getting into our inpatient and crisis type of services. But right there in the middle, the red larger box, that's sort of what our bread and butter programming for outpatient services that most of the community usually think of when they see us. And so within that, we have our flexible integrated treatment program, outpatient programs. It's about 10, somebody correct me over there, 10 provider agencies that are within that we've divvied them up. They all know which school districts they're assigned to, and the school districts all know which of those providers are assigned to them. So this is our way of making sure that we're being able to distribute and provide access and deliver services to all of our school districts within the county. And this is what we consider our specialty mental health services. So these are the more high-end sort of services. So Chris's team are all very aware and familiar with when they run into youth that needs a higher level of service, that they're able to refer them into our existing programs that are assigned to these different schools and school districts. Then they're able to access some of the other things that go along with our program, such as 24/7 support when needed. We also have 24/7. They don't have to be assigned to a program, but we also have other 24/7 services such as we call it the Source, which is a phone line that caregivers or youth are able to call at any time and be able to get support. They can also chat or go under their text on their phones. So there's another array of services. The other thing I wanted to highlight as well is that we also have what we call supporting community connections, which are programs that are embedded within our diverse communities within Sacramento County that already have existing relationships with our diverse communities, are particularly well equipped and well suited and expert on being able to connect to diverse communities. So some examples we have. Now I'm going to blank watch. Church for All of Us, which is working with our African American community. We have our LGBTQ center, which obviously is working with that community, and so forth. There's quite a few of them that are embedded within various number of our diverse communities. The other thing, so that's sort of where it fits within where our two systems sort of collaborate together in terms of getting the right level of service for each individual youth, depending on what they're bringing to the table in terms of their challenges and their needs in a particular situation. Some of the other things I'd like to highlight in this collaboration is some of you are familiar with the MHSSA, Mental Health Student Services, is it ACT? That's being administered by Mental Health Services Oversight and Accountability Commission, and this is also being supported by that funding and that partnership with the Office of Education in order to help get this up off the ground and be able to create that infrastructure that's needed in order for this to be a sustainable long-term program based on the FQHC funding. And then the other thing I want to sort of also highlight is that we also have another amazing partnership where we have it's not a lot of money, but we've each thrown a little bit of money into the pot to create what we call our Youth Advisory Board. And these are made up of youth within our community who have stepped forward, applied. We had a ton of applications. I wanted to say it was in the ballpark of about 100 applications from youth that were interested in coming and advising the county and Office of Education regarding, and the city of Sacramento on the how to address the behavioral health needs of the youth within our communities. So that's a really great initiative. We, again, implemented that through the course of a pandemic. The youth got to be interviewed by their board members in terms of their appropriateness for, and were selected in order to be part of this initiative. And then they self-elected their chair, vice chair, and so forth. We are now a number of months into it. I don't know, I think we really got started at the very end of 2021, so sort of gives you an idea. We're maybe 5 months into their regular meetings, and so we've been giving primers on what it is County does, what it is SCOE does, and sort of helping them understand what the various resources are. And they're getting very engaged and excited about what sort of feedback they're going to give us, and already making plans for what they're going to do over the summer. So it's really exciting additional initiative that we've done as a part of our partnership. So that's the Sacramento County behavioral health perspective, and now I'll turn it over to Jaspreet.
Okay, we'll both go there.
I think we're going to tag team.
Yeah, we're going to tag team,
on
so.
this.
I'm going to take that packet. By any chance? If you want to move it from there.
All right.
Just to enter.
The arrow, the right arrow.
That one? Okay, there you go. All right, good afternoon, everybody. We are so excited to be here. So thank you for still being connected. It's afternoon time. My name is Jaspreet Sodhi, and I have been working as a consultant actually with the Sacramento County for about 3 years now. And it has been an amazing experience working with SCOE and Dr. Ryan Quist and Dr. Mishra, and really building this innovative model because we never thought we could do it. And let alone it's 3 years, and it is happening. And I think it's also the impact at the end of the day. I have a brother with mental health illness. I have been taking care of him for the last 30 years. So this is very close to my heart. So thank you for being here. And really, when we talk about the need, I think you heard from Chris, it's really about the partnership between education and healthcare, right? And I think we had never thought about it. How does health and education come together? And really it is about the unmet need for behavioral health services. You know, I have a brother who has Medicare, Medi-Cal, and yet still to get him mental health services, being myself in the healthcare, has been so tough over the last 20, 30 years. So when I saw this model and a potential for it to be innovative, I was ready for it. And so I'm really, really excited for the partnership everybody has come together. And it is about, of course, behavioral health and primary care. So because we are a federally qualified health center, when it comes to the health center, they provide primary care and behavioral health around the mild to moderate services. But like we were just talking about the linkages, because the kids are going to need more than the mild to moderate, that's where the behavioral health program, the county behavioral health program, and many of the other things I think Chris was talking about sort of sync together. And that's why it's really about the effectiveness of working together rather than working solo. And I think you most probably have heard it over the last 3 days, partnership, 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 and teamwork, teamwork, teamwork. And it's a lot of learning that we all have been absorbing during this time. So you guys already know Sacramento County has an FQHC, and then SCOE has the clinician piece of it, and then all the linkages that are happening. I don't have to talk about the numbers. Chris already talked about it. We all know we have an unmet need. We all know we don't have enough providers in our area. So this is also about really workforce development over the course of the next few years that hopefully we'll be able to bridge those gaps. When it comes to the students themselves, we already talked about there is just the behavior piece that is happening, the chronic absentees. We know about the low academic achievements, but we know about the suspension rates. These are more on the side that you guys most probably understand better than even me, because I come from more of the healthcare side of it. But above and beyond this, this is also clinical care, right? That there are so many kids or students who become patients who have never seen a primary care provider, or who have not even, the parents have not even identified that there are some clinical indicators for these kids to get help. So that just talks about need everywhere that we all know about, right? So here is the idea. So I want to make sure Sumi and me, we both can jump into the idea. So this was, again, 3 years ago when Department of Health Services then director, if you guys most probably remember his name, Dr. Bellison, was connected with Mr. Gordon, Superintendent Gordon, and they came together and said, we have a need, what are we going to do, right? So the first foremost way was to go to the county mental health program and say, hey, you are behavioral health, what are you going to do? Well, there could have been things that are done, but at the end of the day, it's so critical for us to have a sustainable model. Whenever somebody talks about sustainability, it's about fiscal management, right? So at that time, we decided, why don't we shift towards the federally qualified health center that the county, Sacramento County, already has in place. And that is already providing many different services, including as an FQHC, you are able to provide behavioral health services. There was already some behavioral health services that were happening at the Broadway location that we have, that you guys might be familiar with, but it was more on the adult medicine side of it. We really had not discovered and explored when it comes to the kids. Everything that was happening around behavioral health was in pediatrics department, and we have a very close relationship with UC Davis, so we have a lot of the, we have the academic relationship and collaboration, so we had students coming through the system, we had the attending providers, and then there were different programs that were being implemented. But to this level, we had not really thought about it. So why not partner SCOE and the primary care side of it? Because the primary care can leverage the fiscal management through the Medi-Cal reimbursement. We'll go a little bit deep into what that looks like. Now, because we are a county-led FQHC, we get that designation from the federal government. So our federal government department that gives us that designation is called HRSA. So HRSA by statute is supposed to serve the underserved and uninsured population. And out of that comes community health centers. There are different types of community health centers, but the one we particularly have is the homeless program with HRSA and the 330E, which is basically general Sacramento County population that can be served through the FQHC. And because we have the status and some level of funding also coming from HRSA, from the federal government, then by default, if somebody's giving you money, you got to meet their needs, right? So we have something called 21 chapters of compliance that we have to abide by. And I think it integrates really well because if you're implementing a program, you need to think about the monitoring, compliance, and evaluation piece of it. So I'm going to pass it on to Dr. Mishra, and she'll talk a little bit in her role as medical director on how those 21 chapters come into play.
Yeah, so how I fit in, not so much as the medical director, but because one of the compliance that HRSA binds us to as an FQHC is to have a HRSA project director. So that's where my role also is. And so then I have to make sure that our clinic, our satellite clinics, meet those 21 chapters of compliance, and some of those clinical, some of those are budgetary. So that's where my role is. And so what are those 21 chapters of compliance? They relate to clinical documentation, coding in a way that can bill, developing a budget, having a co-applicant board that looks at all of your proposals and budget proposals and getting them signed off. And so that's really my role in this arena. So I can jump right in to say this has been a huge learning thing for me, being an adult medicine doctor, and all of a sudden mental health in children. And so very, very important. And so I'm learning a lot. It's been amazing. I'm so thankful that this innovative approach came to the health center. But we've been trying to understand how to learn more about what happens in the schools and what's happening there, and get outside of our box of a clinic setting, and then also introduce those same concepts of what we do to the schools and the clinicians working there. Specifically, I'm sure that the clinicians have their own documentation templates for another regulatory body, but for HRSA compliance, we have to specifically, create templates. Again, as I was mentioning, to support billing and documentation, we have to have a peer review process. We were just in discussions yesterday about what does that look like in the schools? Who's going to do a peer review process? What chart audit tools do we use? And so now there's this whole level of things that we're doing at our regular clinic for all of our clinicians, but the SCOE clinicians themselves are our contracted employees, and therefore, by extent of that, we have to have them follow the same sort of compliance rules. So that's basically what our role in here is, and then the second part, which I leave to the billing guys, because I just don't know that stuff. As long as the coding and documentation is done, it goes to our clinic finance team, and then via our electronic health records, they send that off. And as Chris mentioned, we're getting paid. Yay! Sustainable model, right? Let's see if it, and we're going a step further. Jaspreet being our CEO consultant, she's been actually developing contracts with the mental health, with the managed care plans themselves, so that in addition to this PPS rate that we receive from the state, we will also get something from the health plans themselves. And so we have already enacted, out of the 4 GMCs, 3 I think are executed. If I'm not, 1 is almost there. And then Jaspreet's in conversation with Kaiser right now, and we're keeping our fingers crossed that. So then we will actually have a specific carve out. So not only having that PPS, those PPS dollars going, generated by the clinician visits, but in addition to that, something from the plans themselves. So we're really hoping that this is a very sustainable model, and so we're super, super excited about that.
Can I jump in a little bit
Sure.
to the financial model?
Yeah.
So just to get you guys an understanding, if you look at Sacramento County, it's different than other counties. So, Sacramento County and LA County are similar. They have the GMC model. All other counties, like we just heard about Solano County, they have one plan type of a model. So in Solano County, you have partnership health plan, and behavioral health services are carved out to Beacon. So partnership is supposed to take care of primary care and some other additional specialty care, but not the behavioral health side. But if you look at Sacramento County, you have 3 IPAs. The main ones are River City Medical Group, and the other one is Nivano Health Plan. So if you then look at the IPA model, they're supposed to only cover for primary care services. So then if you look at them, there are 4 health plans underneath those models. So if I take an example of River City Medical Group, they have Anthem, HealthNet, Aetna, Molina. So because all of that carve-out is supposed to happen there, we at that point now had to contract out with all of those. Now, one of the things that was very, very important is not to leave any student behind that needs care. It's not always about the health plan or the payer. Yes, it is about convincing them, saying, we are taking care of your kiddos, so we need you to have a contract with us. And so one of the other ones that we were missing is Kaiser has the Medi-Cal side, which we wanted to make sure those kids also receive appropriate care. And so that's how the conversations with Kaiser came about. Of course, we are also seeing some commercial plans that are popping up here and there. Our goal eventually is, if a child is in crisis, see them. And then if they have another behavioral health provider they need to be sort of connected to, then we're going to reroute them to that behavioral health provider. But do not look at the insurance card and say, I can't provide care. We are going to provide care. And so the other thing, I just want to give you guys an idea. You're hearing this word about PPS rate. I want to make sure you guys understand. So even though the health plans are supposed to cover for behavioral health services, the benefit of being an FQHC is that we get an extended Medi-Cal enhancement rate. So let's say for a visit, that's a behavioral health visit, mild to moderate category, we get paid $50, right? Now, because of we have an FQHC, the state, because of the prospective payment system, is supposed to help us with the whole. So let's say that is, it costs me, and it's an overall cost for the clinic, it costs me $200 to see a patient. So if I received $50 from Anthem, then there is a differential payment that's coming from the state, and after 3 years, after actually 1 year, it takes too much time to get paid, whatever they owe us, the state, we do what is called a reconciliation of the books, and the state can owe us, and we can owe the state. So just to give you guys an understanding of the jargon, that our goal is that we have that contract with the health plan, which gives us ability to then build the Medi-Cal system to get the reimbursement. The other thing on the previous slide that we talked about compliance, also remember it talks about what happens if you cannot take care of the child? What are you going to do? So you have to have memorandum of understandings, which is what linkages are about. How are you going to handle that patient that does need additional care? Also, even though we are a Sacramento County, we have our own patient population because of the health plan model. We are also making sure that all the health centers that are in the area, you have the ELICA, the One Community Health, all these other community healths, they are the primary care home for these students, right? So our goal is that if they do require any primary care and they had never seen their doctor, we can help them get linked back to that model of care also. So it is a very robust system that the compliance piece actually puts some accountability on us, and being that we have a subcontracted model the way we have with UCD and Couny now, then we are providing that level of structure of monitoring and sort of technical assistance to these different programs that are serving the population.
So when Dr. Mishra said a couple minutes ago that it's been a learning, she's learned a lot. We're all learning a lot, right? Like 3 years ago, I didn't know what a PPS was. And now the complexity of this model is really profound. And I just want to go back to where we started, which is the partnership. I think it would have been pretty easy at any point in time for one of us to kind of throw up our hands and just said, like, this is too much, because it is, quite frankly, it's too much. But I think because of, what Jaspreet shared, like each of us have been touched in our lives by this. And we continue to come back to that, is that the mission of this is really critical. To say it's important doesn't really do it justice. The mission is it's necessary. We have to do this. And so coming back to this partnership and coming back to how we support one another through this complexity is like, okay, there's another layer to this onion. So, okay, let's wipe the tears away as we peel this onion and let's get back to work. And I think that's what we've really done over these couple of years.
Yeah, and that's just what I was going to jump into is that in case anybody else is going to want to try this model too, is that there's of course been the challenges and some of the things that you just never think about, So training a whole group of people on our electronic medical record system, and that's not an easy job. Even doing electronic medical record system day in and day out, I'm like, oh, I had no idea that I can do that. But, so to get the clinicians' buy-in and the training that has to happen, then you've got the registration piece. The schools have to have the EMR that we have in our clinic. Well, that's not easy. That's not very easily done. So now we're trying to figure out how to do a real-time registration process so that we don't lose the student right there that needs services, that needs to be registered, but we don't know their insurance information. And that registration person at school doesn't know how, maybe the easiest way to enter that information. So we got to get that back to this clinic, and then our clinic staff has to be sitting there by the computer and being like, oh, just got a message from school, got to register. Patient, it doesn't happen that perfectly, So then what do we do? So, now we're via a grant looking at a way to extend VPN licenses to the school, but we can only find 50 VPN licenses, but it's a start, right? And so how do you extend those licenses to the school so that they have the full functionality to do what our registration staff has, training registration at school to do some of that while we're still working on having this like real-time process. that's some of the things that I can think about that we're still trying to figure that part out. Yeah, mostly I would say the technology has been challenging, just understanding the two entities. But like you said, we're peeling the onion. We cry for a bit, and then we get stronger, and we're like, we can do this, and we just keep going. So actually, I don't have any more to say. That's how the whole program's been set
I
up.
think there's a future.
And there's a future.
There is a future.
There's a future. And we're glad there's a future. So, yes. As Jaspreet was mentioning, expanding our contracted payer mix and a system so that we can see anybody and have a financial sustainable way to do so, whether it's just PPS rate, whether it's some grant money, whether it's some other state incentives that are occurring. Building up the right staffing, again, at the beginning of this, I don't think we knew registration would be the biggest hurdle, but it is, believe it or not. Getting navigators maybe to do that, or to reach parents if we need information and we can't get the information, if the schools can't get the information from the kiddos. So to get to have a navigator, hopefully, and county as a whole, General Department of Health Services is looking for a better health information exchange, which I think will also facilitate a lot of what we do, expanding to every school in Sacramento and getting more stakeholder involvement. So with that, I think I'm going to turn it over so that people have questions.
Yeah, and I think one of the people we didn't mention is Siobhan Kothari,
Yes.
the current director of Department of Health Services. She has been really the spearhead from our end on the county side that has really supported this model. And so from Superintendent Gordon to Siobhan Kothari in the background, and then we're working in the front, but then when we have challenges, we got to go poke them, tell them what we can potentially do. And just, the calls that we have, they are just so exciting, and they're so innovative, and there's just so much positive energy. And 3 years ago when we started, I knew we could do something, potentially, it will work. I remember in my head saying, this can work, totally work. But then the little challenges I think we saw from registration, I had never ever thought registration was going to be an issue. Consents, we never thought that. We never knew that we are going to see above and beyond the health plans that were in the area, especially now with the Kaiser work that we are doing and commercial plans. And I think this whole concept of social information exchange for all this work that is being done, because everybody has a different electronic health record, right? How can that all come together? How can we have data? When you start evaluating, you need the data to be able to see where did the shift actually happen. So I just wanted to make sure we mention all of the people that have been in the background doing all this work. So thank you for having us. Thank you.
Alyssa got her hand up first.
Okay.
All right, we'll go this way.
You touched on both of these things while I was thinking about putting it. So the answer might be navigating so the consent, right? So my question is, at what point and how or who gets parental consent? Is it before registration, during, after? I assume if there's a crisis and there's funds and how do you navigate the parental consent piece?
Yeah.
Chris, just repeat the question. Everybody might not hear that.
Sure. How do we navigate the parental consent piece? And so the clinicians currently are doing it. The clinicians currently are doing everything at the schools, which is not the model that we want to do moving forward, which is how we want to, the reason we want to bring on family navigators. And we're looking at our SB HIP proposal to fund the navigators starting in August. And what that would be is there's a pretty cumbersome registration packet. That's why we keep coming back to registration, is because it's currently a paper packet. And when we were doing this in the first year in the middle of COVID, we were literally mailing out these packets with a self-addressed stamped manila envelope that would come back to SCOE. We would take the packet, we would scan the packet into Microsoft Teams because it's HIPAA compliant, send that folder via Microsoft Teams over to the clinic. They would then access it through a one-time link, download the packet, and then print it out and then upload it into the EHR. So when we're talking about challenges, like every time I say that, I chuckle a little bit. I'm like, oh, we really did do that. So now we have an electronic registration system that we're working on right now. Not perfect, but we're able to send a link to parents, and it's as if like we all refinanced our homes in the last 2 years, right? So it's like the DocuSign that you get with your financial documents. It's the same sort of a thing. So we get verbal consent over the phone. So we can proceed with verbal consent until we actually get the paper, the signed consent. And then, of course, best practice is to get the parental consent regardless, but we do know that youth 12 and older can give their own consent along with the clinician's judgment on that. So wordy answer, but get used to it. There's no simple answers in any of these things, yeah.
Richard?
So, yeah, thanks for bringing this model approach forward. It's very thoughtful, innovative, creative. I love it. While the funding is complex to set up, to other collaboratives, from my perspective, it's actually pretty clean and crisp. So kudos for stumbling onto it or identifying it. Three really quick questions, I think are quick answers. At the point of referral into cost, is there a methodology whereby the person receiving the referral processing can cross-check the larger system of care to make sure this young person, student, is not in service somewhere else outside of the collaborative, that is child welfare, juvenile probation, MHSA, and community family resource centers? Can you network that to make sure we're not treading onto the family's existing providers?
Not currently, not with the, not currently simply, right? It's the old school method of just asking and making phone calls right now. And that's why we set up the collaborative, which started with the FIT providers. So the FIT provider clinicians and our clinicians literally got into a virtual room and started chatting with each other. And then we said, oh, we need to fold the advocates in. So we brought the advocates in, and now we just recently brought CPS in, so that it's almost like that where it's the 80s where everybody needs to have a Rolodex and like call the person to whom makes the most sense, until we get that social health information exchange up and running.
So that's a developmental opportunity, right? Which leads to the second question, which is what's the interface? If you could just articulate a little bit. This ties us to our content yesterday in this session, which is what's the interface between this part of the collaborative and your larger child, youth, and family system of care development under P2083, where you have a broader network of providers in the community. Have you thought through how that interagency leadership team can support your effort and how you'll nexus back to the system development?
Chris, before you answer, try to paraphrase that.
Yeah.
And then Richard, the next, you have to stand up and speak louder.
So, okay. So AB 2083, the state mandate for improving collaboration at the county level around systems of care, specifically for foster care. But the question is, how are we, our clinicians, interfacing with that 2083 leadership and advisory group and then back down?
Less at the clinical level, more at the systemic level, so that your ILT knows what you're developing in this little collaborative.
Yeah. So several of us are on the 2083 group, so we were able to give updates in that regard. And then we're building a data dashboard, as you well know, around shared goals for that 2083 group. So behavioral health, Department of Health more broadly, and SCOE all contribute to that dashboard around our goals. How are we supporting our goals, and how are we interfacing around those goals? So I would say we're at the beginning stages of that, but I think that's why I'm personally really excited about the social health information exchange, is I think it's a step towards that larger system data integration, which we've all been talking about.
Thanks a lot.
Sure.
Hi, I'm not super familiar with county-run federally qualified health centers. Very familiar with the nonprofit community-based FQs. So I'm curious, does every county in California have an FQ status? Okay, no.
Only if they choose to.
Okay,
In some cases, they even partnership with other health centers that you are talking about.
yes. So I'm wondering if you could unpack a little bit the pros and cons of a county office of education partnering with a county FQ versus other community-based federally qualified health centers.
I think it could happen either way. So we actually have had some conversations exploring whether or not we might want to pull in some of our other community FQHCs at some point. So I don't think there's, do you think there's a plus or minus?
Actually, yeah.
PPS.
One, from a financial point of view, county-led FQHC's reimbursement is a little bit higher, because when they're building their cost, it's we have more allowable cost. Also going back to what Ryan is talking about, we are already interested in talking to other community health centers, and there's a reason for that, because other community health centers already have school-based behavioral health or primary care services that they are providing. So rather than us going in there, why don't we partnership with them and collaborate if they are providing that care? So I think definitely, in fact, as we were getting letters of support from a couple of the community health centers, as we will continue building, there were some health centers who said, hey, we already have an LMFT or LCSW or even an MD providing primary care. So then it was all, okay, so what if we can actually take that part of it and make it part of our collaboration? Thank you.
Yeah, I would just add one piece is, I'm just full of analogies, right? My head doesn't operate without analogies. And one of the analogies that we've talked about over time is like, like when you go out to lunch, when you take your kids out to lunch, like there's that, on the little kids menu, there's the connect the dots activity, right? It's like the dots already exist on the page. It's not until you start to connect them does the picture emerge, right? Well, in Sacramento County, there's tremendous dots of work that are happening in isolation of one another. So if we start to connect those dots, what's the picture of an integrated system of care that's going to emerge? And so I think that what we want to do really is not say that our way is the only way, but more importantly, our way is one way of convening and connecting the dots so that we can really see a great picture of a system of care emerge in Sacramento County.
Well, I think I'm trying to stay on time. I think you kept us here.
Sorry.
Yeah. Right, we have 2 minutes here, Steve.
Going fast.
I do talk fast. The first thing I want to say is I live in Sacramento County. I worked with Judy Holsinger when she was at the state SELPA and another SELPA role here in this county. And the most frustrating part of my job was working with county mental health because I couldn't get services for my kids. And it drove me nuts. So I am so grateful and thankful that you are now doing this. But Shelton, who also worked in Sacramento County, and I were back there saying, they're not saying anything about EPSTD dollars anymore? Is that part of your Medi-Cal funding that you get, or you get them, or how's that working?
That's part of our FIT programs that we talked about. So the county contract providers would be part of those EPSDT dollars.
So you do get them now?
Yes.
Yeah, good. I argued that.
Okay.